No, not at all. I think it was a very good summary. Yeah, yeah. Very active
Great.
research as well. So yeah, that's great. Thank you.
And we thought to keep it as a chat, as an interesting chat. And for us, it would be great to ask you some questions, if that's okay for you, if you're happy with this. So I would start with the first question, and about classification. What kind of classification do you use to assess unstable shoulders? That's maybe the main topic you cover. What are the pros and cons of the different classifications?
Okay, well, I mean, probably the one that most people know me for is the Stanmore classification, which we'll be talking about in some detail when people attend the course in Milan. But essentially, I think the main thing is keep it simple. There are numerous classification systems out there. Probably the one that's most familiar is the one by Thomas and Matson, which is Tubbs and Ambry. And effectively, Enrico, what we tend to do is divide unstable shoulders in either those that are due to trauma or those that are not due to trauma. The Stanmore classification, in brief, basically evolved from the Tubbs traumatic, unidirectional, Bancart surgery, and the Ambry group atraumatic, and they basically used that system to then develop the triangle system. And in summary, what I would say is the thing about the Stanmore classification is that it defines three key groups: your sort of type 1 traumatic, which is the most common, your rugby, soccer, skier, high forced injury, there is a structural problem, and often the recommendation treatment is often a surgical solution, particularly if they're highly active and sport related. And then as you come down the axis, the right hand axis of the triangle, you then talk about the atraumatic group, so that the Ambry group, as Matson described. And this would be patients who may have developed pain, symptoms of instability, but there's no obvious structural lesion. So it's often a minor treatment. I often talk about you either born a bit loose or you become a bit loose. You know, the shoulder starts to become a little bit pathologically lax. Patients start to experience subluxations or pain, feelings of instability, but there's bone trauma. And when you scan their shoulders, there isn't any obvious bony damage. As you then come along the bottom axis, the third group, which I have to stress to the audience is really quite rare, but these are the group that we term people with a muscle discoordination problem. So to kind of think of the top group, the trauma is your shoulder has been pulled out by force. Yeah. Bottom group is your shoulder is not being held in very well because you are lax and the muscles are not strong enough to hold you. And the third group you could often describe as they are born lax, but the problem is now muscles are discoordinating. So not only do they not hold the shoulder well, but they could also create a feeling of instability. They can pull on the shoulder. That third group is called type 3 muscle patterning, often seen in people with hypermobility disorders, collagen problems,
for example.
And can sometimes then have a feeling of a party trick. So can sometimes voluntarily displace their shoulders. But the reason the classification, I think, works is because it allows you to have a continuum between the groups. So what it says is you could be, let's say, somebody with a structural problem, but your muscles can also start to discoordinate. So for me, we've lived and breathed the Stanmore classification. It's now being taught within most orthopedic textbooks, and it is referenced in quite a few papers. But I would also say there are several classification systems out there that all have to some degree a general theme that runs through atraumatic versus traumatic. The only thing I would add, Enrico, is that most classification systems are based on a very biomechanical model. So when we talk about instability of the shoulder, we're often talking about it from a biomechanical perspective. Either is there structural damage or are muscles working incorrectly? And I think one thing that I've started to discuss really is that we almost need a classification system that also includes the psychosocial I think that's really important. So I think for the audience, these classifications are often developed from a surgical perspective or from an orthopedic surgical perspective. And I think sometimes we forget that it's not just about the mechanics, but also the person and some of the psychological factors that can drive. A good example, a simple one, is that fear and anxiety of pain and apprehension can create muscular disorder. But when you have a classification system and you say it's muscle patterning, it's difficult. That classification doesn't allow you to fully understand all the things that may go behind it. Does that make sense?
It makes sense, and it happens the same even in other areas, no? Like in the lower back pain, or in other potential complex, painful syndromes in which you can experience something like this, and you have to take into account the whole person, not just the the anatomic or the biomechanic.
And that comes on to your second question about the pros and cons. I think the good thing about the TUBS and the Ambry classification is that it's simple, easy to follow. So you want classification systems where they're repeatable, that people can interpret them correctly. It's difficult that not many classification systems have been truly validated or looked at reliability. One of the disadvantages of the Stanmore classification, for instance, is that if you saw a patient and I saw a patient and Fabrizio saw a patient, we might classify them slightly differently. Does that make sense? So where on the axis might they sit? So the intra-reliability, inter-reliability has not been properly tested. But in terms of decision making and in terms of understanding that there is dual pathologies that can coexist within the shoulder, I think the Stanmore triangle is very helpful and is a good pro. And then we discussed that what it doesn't do is always understand the psychosocial aspects. So we have to have something else that complements how we manage patients.
Yeah, because it can change a bit the management, at the end of the day. So having someone with fear or with anxiety instead of not having them. Thank you, Anju, for your answer.
Thank you, Anju. Now it's my turn with asking you another important topic. So the referral to other professional. So my question is, refer or not refer to the orthopedic surgeon? What are the main elements to evaluate for referring?
Yeah, okay. I think, Fabrizio, if we take shoulder pain generally, and if we go with the idea that most people who come with a shoulder complaint, usually in the middle age group, it's usually cuff related type of shoulder disorders. Probably the key factor at the moment of when you want to seek an orthopedic opinion very quickly is, I think you need to think about the red flags. And what we talk about is things like what requires urgent referral. So trauma would be something that would be significant. So I think it's important to kind of think about the mechanism. So if you have someone coming in with shoulder pain, but there's been a significant trauma to their shoulder, then you need to be worried about what has happened structurally to the rotator cuff tendons. Has there been a fracture? Also think about any kind of nerve damage that could be related to the problem. So I think a threshold for referral quickly is probably trauma, so that we can get the necessary investigations done and then decide a better plan of management earlier than later. For most other shoulder pain, which develops more in a kind of insidious onset, so there's not what I call is a degenerative process, an age-related process, an overload type of injury. I think in those scenarios, there isn't that need to go for urgent orthopedic referral. For most of those patients, we know that if we do appropriate rest, modification of activity, we improve some strength imbalances around the shoulder, 80% of those patients could respond very well to non-surgical treatment. And our surgical colleagues would also agree that they would prefer to see those patients usually following having had good therapeutic treatment before they would consider surgical options. So when it comes to the cuff related, I think trauma is a big factor. There are other red flags that you need to think about. So if you see any swelling or redness around a shoulder. So in fact, I saw a lady just a few weeks ago who came in. She was referred for rotator cuff related shoulder pain, but when she took her blouse off, you could see there was a really noticeable swelling around the shoulder. And interestingly, she had contracted pneumonia about 4 weeks prior to that. So immediately, this looked like an acute bursitis. And one of the big risks are one of infection. She had been unwell. And that kind of patient needs to urgently go to an emergency department, probably to get the bursitis dealt with from an antibiotic perspective, check for an infection, and maybe have the effusion removed. So there are certain red flags where you do but trauma, redness, swelling, and then obviously when you have what I call cases which just don't fit the norm. So any kind of risk of a cancer diagnosis. So, patient generally feeling unwell, persistent pain, pain levels that are sort of not easily explainable. There should always be a high level of suspicion when you get a young patient, for instance, below, in their 20s, coming with acute or absolutely excruciating pain and stiffness in the shoulder. Those for me would be big red flags that would seek urgent referral for imaging and orthopedic review.
So always to collect anamnestic data and to collect objective sign is always mandatory. Yeah. Thank you.
Yeah.
Thank you, Anju. It's very interesting. And dealing with red flags, they are maybe not that frequent and they are quite rare, but when you have them, you have to be sure enough to refer them to someone else. Otherwise, it could be a real mess, no?
Yeah, absolutely. And I think you can sometimes simplify it. To see stiffness in a young person is unusual, particularly without trauma, So, and even if you do have a young person with a stiff shoulder and there has been trauma, you need to start thinking about, is there bony injury? Is there a missed posterior dislocation? So yeah, there are definite things that you need to be, and that's why we come back to the idea that your clinical reasoning and your clinical assessment is assessing the person as well as the pathology.
Yep. Exactly. Yeah. Okay. So I read your the content of your course. The course you are delivering soon here in Italy, and there is like this expression, reframing shoulder pain. What do you mean exactly for reframing shoulder pain?
In summary,
that's a bad question, huh?
Yeah, no, it's a very good question. I think it's well meant. I think for me, it's really broadening out to that biopsychosocial model of care, Enrico. I've been in clinical practice now for 30 years, and 25 of those years have been purely managing shoulder and elbow problems at my hospital. And I think historically the way I was taught and the way we manage shoulders was from a very kind of biological, pathological, mechanical way. And even for us as a unit now, we're realizing that pain is complex, it's multimodal, it's multifactorial. And that sometimes the way we have to manage patients is look at the other contextual factors such as environment, psychological elements. So when I'm talking about reframing shoulder pain is in the light of where we are with current evidence now, and the importance of that psychosocial model, but even more important in physiotherapy, because we now understand that the treatments that seem to be most effective are usually exercise prescriptive treatments. And you know, and I know that in order for exercise to be beneficial, people need to engage in it. They need to understand it. They need to feel motivated. And I think the importance of the course that we're going to talk about really is actually how do we start to reframe the way we get patients to engage with self-management of their shoulder conditions, to empower them to be able to do exercise, to increase their self-efficacy, so give them the control over their problem. And it's challenging because we're moving from a powerful position of where we as therapists were doing things to patients, but instead moving into a position of coach and mentor, guider. And I cannot stress how important that is. It's not belittling our role, it's not undermining our role, but it just enhances our role in a different way. And we know through evidence that it can be cost efficient, but it could also help with longevity of patient self-management. So I think in answer to your question is reframing from the context of what the current evidence is now telling us and how we need to shift our behaviors and thinking around that what we talked about, that coaching type of style of motivating patients.
Yeah.
Whoa. Wonderful.
I would just add that you still need to have good biomechanical knowledge, and it's kind of what's been so good with the last few questions you asked, because people are more likely to engage, motivate, and be driven in what to do if you do have a good scientific understanding of their problem. So you also do need to understand the biomechanics. You also have to understand the pathology. You have to understand when that pathology is relevant, when it's not relevant. How do you reassure a patient? How do you demedicalize a problem? When do you think it is appropriate to scan or not? So you can see that skill set's still required. And if you get that right, then your ability to prescribe exercises will be made easier and appropriate.
Yeah, exactly. I completely. This is great. Even thinking about how we, how other soft skills we can get and improve, because we are not, at least here in Italy, we are not that good, or we are just in the last few years we are trying to make this change, in the way we can deal with several complex, at least, patients, but it can be done even with patients that are easier, and it can make the difference in a matter of thinking about the adherence to the plan, to the exercise plan, or whatever it is. If you can, if you are not perceived as the expert, but as something else, like a coach or a guide, we can definitely maybe make a step forward. So yeah.
Yeah, I think, and also it's interesting because I think you were sort of saying to me in Italy that things are beginning to move in that direction, but you're still a little bit perhaps the UK, Australia, we're a little bit more ahead in that kind of motivational interviewing. And I think one of the things that we've also got to be careful of over here in the UK, Enrico, is that we do not swing completely the other way. Sometimes have students come to the hospital to learn, and they're being taught the biopsychosocial model, but then they almost forget how to assess the shoulder. You know what I mean? It's like you don't want to throw some of your skills away, but you have to have that broader understanding. So we've got to be careful that we don't just think, okay, well, it's just talking therapy. It's also putting some kind of foundation and context behind it, which still requires some clinical.
I completely agree with you. And the biological part of the bio-psychosocial, it's the base. It's like it's fundamental for everything else. Then so we are not that good at assessing the bio, I would say, part of the cake. No, we are not that good as physio, but you know, at least we should be good enough to go and try, no, to do our best to evaluate that part. And there is even something else that can make the difference in the more complex scenarios or with more complex patients. But yeah, completely, we don't have to forget the basic element of our assessment management. And, you know, yeah, I completely agree with you. Thank you for your answer.
It's quite nice because I think it dovetails into your next question. Possibly the other question.
As regarding with this topic, I want to ask you a question more about biomechanics. If biomechanics matter in subject with shoulder pain, and if it, for example, could influence the management, for example, exercise prescription parameters, and also prognosis, positive or negative prognosis.
Yeah, I think, do you know what, I was thinking about this, and it's actually it's really interesting because the more research or more evidence is coming out. Let's take that maybe the most important thing for us as therapists is we've often explained to patients the reason why they have shoulder pain is because there is weakness. And we often talk about that there is a lack of strength in external rotation, for instance. Now, it's actually, I think in Italian, it's Mestro's paper that talked a little bit, they looked at people with cuff-related shoulder pain and measured their strength in rotation pre and post intervention. And this was a non-athletic population. And they didn't find a direct correlation with strength and pain, and also change in strength and pain. And that's interesting. And then we also now have the SEXY trial from the group Michael Clausen in Denmark, where does increasing higher strength loads when training for cuff pain give any superior clinical improvement? And it doesn't. So the answer to your question, Fabrizio, we kind of talk about the biomechanics, but when it comes to strengthening of the shoulder, there doesn't seem to be this direct relationship with the stronger you are, the better your pain, or the lesser. It's a more complicated element than that. But I think for the moment, what we can say to patients and what we do know helps is that we know that any kind of strength loading can have benefits in terms of it improves capacity and capability of a muscle to perform. So the stronger and the better strategy you have at your shoulders, the more likely you will that you won't fatigue, you'll be able to carry on activity. But also, is it that exercise has a very positive psychological effect on endorphins and our mental well-being? And could you therefore argue that is it just shoulder exercises from a mechanical perspective we do, or just bring in more global exercise? Because what we do know is that probably the best medicine for any kind of pain or depression or anything that we're doing is exercise therapy. So I think it's more. So the answer to your question is, we're still I don't think we still fully understand. Interestingly, we always thought that strengthening up the shoulder there was good biomechanical reason, therefore, why the shoulder pain get better. But I think it's more complicated than that, Fabrizio. And I think as we're going further, maybe it's not the biomechanics of strengthening the cuff, but just doing exercise that seems to have a very positive beneficial impact, both on chronic inflammation, helping with functionality, just how you feel about your pain. Do you see? Yeah, I think it's more than just biomechanic influence.
Completely agree. That's
the only thing I would say, and the work that could be interesting, is that I think what's fascinating is when we look at patients who we know have a full thickness rotator cuff tear, for instance, or have more than 2 tendons damaged in their shoulder, but still have this.
Yeah.
It's also interesting in that people try to find biomechanical reasons for why that still works, and the argument might be is that it's because perhaps there is still integrity between the cuff at the front and at the back. Is it because the deltoid learns to compensate, or is it as simple as the fact that actually by making sure that we keep mobility in the shoulder and we do some general exercise, that patients feel more positive and better about their shoulder? Does that? I think there's a lot of unanswered questions, which I think is fascinating. Why do some people do really well with massive rotator cuff tears and others do not? And it might not just be because of the biomechanics.
Yeah. As always, the answer is like multifactorial.
Yeah, exactly. But then it's actually nice and interesting in that if it was so simple, we'd be able to fix everyone, you know. And it challenges, and it's what I've really loved about treating shoulders, especially, is that even in my 25 years, I feel like there's kind of almost more questions, and it gets more interesting, and you think, why did that treatment work for that patient and not with another? And maybe what's great, Enrico, is it's allowing us to also, like I said, broaden our perspective on understanding the more holistic element of the patient in front of us, rather than us before being very prescriptive in the way we prescribed exercises.
Yeah, completely. That's paramount. It's very important. Yeah. Yep. Thank you, Anju. And then, so this is quite. It's another question. We have just talked about the importance of exercise, and exercise in the various in various ways. And what's the role instead of the hands-on approaches in this group of patients? I mean, in the group of patients in the this kind of patient with unstable shoulders. When do you think it is appropriate, and when it is not that relevant, is irrelevant?
Yeah, and are you talking particularly about instability or cuff-related shoulder pain, or either?
I'd say we can talk about unstable shoulders, then we can move to cuff-related shoulder pain, painful shoulders.
I mean, what I would say is with instability, the problem is very rarely one of stiffness. So it's not like you're having to particularly do a hands-on approach to stretch or mobilize. These people have mobile shoulders. The problem is they lack stability. The question around hands-on, I think it depends on how we're terming that. So for instance, let's talk about things like modification, symptom modification testing, which I know people may have heard from various people. Jeremy Lewis talks about it, Joe, various shoulder experts. And you could argue that when you place your hands on a scapula, when you support the weight of the arm, it's a hands-on approach. It is the therapist placing hands on the patient. And what you're therefore doing is you're modifying the way the patient moves. You are facilitating or assisting the way that the shoulder moves. And you are therefore providing some kind of feed forward, proprioception. You're also providing a psychological support. You're reducing the fear. You're helping the patient sense what they do. So this thing about hands-on approach, I think in that context can be incredibly helpful. We know that when a patient comes to us and there is the ability to show them how to move, to show them how to move without fear of pain, reducing instability, that can be a really good way of getting patient engagement, getting them to understand the problem. So I would say is that there is some role in the sense of you put your hands on a patient and facilitate that movement. But what I would also say at the same time, that when you look at the evidence and when we look at clinical trials, and I'm now going to talk about more like cuff-related shoulder pain, there is very very low level evidence to really say that direct manual manipulation at the shoulder girdle is any way more superior than if you just do exercise prescription alone. So what we're saying is yes, those treatments may be giving you a positive effect, but they're not superior or are required to still get a good outcome. Yeah. Direct mobilization of the shoulder is not required when treating rotator cuff related shoulder pain. Now, you might choose to perhaps do some manual treatment to the thoracic spine to help with improving shoulder range of movement. But we know with the clinical trials that we've done that if patients are given good education, early reassurance, and what we came back to, which is encouragement to do the exercises, direct hands-on treatment is not required. Those patients get a good outcome without it. I would say for you, in my clinical practice, as my practice has evolved, I do less and less direct hands-on treatment to patients. I don't even do that much symptom modification now either. I found ways of positioning patients in different planes and directions to get their muscle activation happening, and I find that's helpful for them because then they're in complete control of it. They don't require me to put my hands on in order to feel confident. Does that make sense? So my approach with shoulders has generally become more hands-off.
So it's the intention of using your hands, and even maybe with some particular, I don't know if with stiff shoulders, maybe.
Yeah.
It can maybe
with stiff shoulders. I think even now, for instance, with stiff shoulders, the problem is one of lack of rotational movement, either in external or internal. But even now, I'm actually doing a lot more high level loading, so eccentric loading to improve that range. So what you're doing is you are effectively kind of stretching, but the patient is in control of the load effect. So what they're doing is they're eccentrically loading a muscle to allow that muscle to give enough to get to that range. And the fact that they are actively involved means that they're also co-contracting and making sure that then another part of the antagonistic muscle is working to keep that stable. So I have to be honest, I don't see a lot of very, very stiff frozen shoulders in my practice. And even now in England, if they are very, very stiff and they are very painful, most patients will receive an injection, a glenohumeral joint injection or a hydrodilation injection. But I would also say to you is we're getting some good work, and patients have also said to us that amazingly, even in frozen shoulder, when you give people really good reassurance and you've excluded other pathology and you've provided them the diagnosis, interestingly, that goes a long way for the patients then to get confidence to move again. The problem I think we have with frozen shoulder, Enrico, is that when your glenohumeral joint cannot rotate, and we know that when you need to get elevation, you need rotation, you need external rotation, is that I think the problem is a lot of these patients will move with their scapula. So what they're doing is, in order to get there, they will compensate. The problem then is they get a lot of myogenic pain, I think, and a lot of muscular discomfort because they're overworking so much of levator scap and trapezius muscles, and I think the discomfort they continually have then is the muscular discomfort of having to compensate. There is no doubt that if you do some soft tissue massage or if you release those muscles, it will feel therapeutic for them. But I think in order to improve the primary driver, it's one of how do you start to get the cuff to work properly like a cuff again, and how do you reduce that pro-inflammatory irritation that's going on. So I think again it's understanding what's going on from a pathological perspective. But my feeling is even with frozen shoulder now, I think some of the work around doing eccentric loading exercises, early reassurance, good diagnosis, injection therapy may be of benefit. It is kind of showing us that these patients can do well. So the hands-off approach, I think it's in a context of kind of, I suppose, the sort of clinical reasoning model that you're working with. But my experience generally is I had underestimated how important what you say is and how you say it. And I think if you get that right, a lot of patients don't feel they necessarily need much more than that.
Yeah, completely. Yeah.
So let's shift to another important topic as a return to sports. And another question is, what are the main goals for dealing with athletes with unstable shoulder who wants to return to play? There are some specific tests that you use for understanding when the athlete is ready to come back to sport?
Yeah, so I think there are quite a few objective markers. And I think if you kept it simple, strength ratio is probably important. So people talk a lot about the internal and external rotation strength at the cuff and the shoulder girdle. People will use sometimes handheld dynamometers to measure that, but essentially based on age and sex, and now there may be some normative values of certain sports. Now, I don't do a lot of sports athletes, but I know that people like Anne Cools, various other authors have shown what normative values for strength might be specific to sport. So that strength, a balance of strength, both in external and internal rotation. Range of motion, obviously, you need to have the range. So have people got the flexibility and enough of, and particularly in throwing athletes, is you really do need to get those end range positions in extremes to be able to get the forces that you want to generate when you're throwing. So it's standard in terms of the strength ratio, the balance of that, range of motion. But then I think one of the things that we probably don't do enough is you also need to look at proprioception, and there are several elements to that, Fabrizio. So you need to look at speed. So even though you may measure of strength, you need to look at, can people react in a fast way? So can you start to do things in a quicker sequence? Speed is one. Accuracy of movement, so the ability to re-find a position. So for instance, I might get a patient to close their eyes, place the arm in space, then close eyes and repeat. So have they got the ability to understand where their shoulder is in relation to the rest of their body, but in space? Can they do things with speed and reaction, and also force generation? So the ability to know how much force to apply. For instance, you could do that by getting a weighing scale and ask the patient to place pressure through the limb, and then with their eyes closed, repeat that. And can they generate? So generation of pressure through the limb, speed, accuracy of movement are all things I think are also important with regards to kind of factors that you're looking in terms of a neuromuscular control system. And then obviously confidence. Now confidence will come if you feel strong and you've got mobility and you're not worried, and you can fit objective tests, then that gives you psychological confidence. But there is also, are you ready to return to play? Is there that fear or worry of re-injury? And there is a psychological questionnaire, the CERSI tool, that people can be given to look at their readiness to return to back. There are various tools that have been validated that are out there, Fabrizio, that people use, such as things like the Y balance test, the CQ Quest test, which is a kinetic chain with upper limb function. You also have things like the ASH test, looking at force generation, Ben Ashworth's test. And then some really good colleagues and good friends of mine that I've known through the shoulder world, people like Margie Olds in New Zealand and Adele Flanning, in Ireland, have also done a lot of work around looking at objective markers. And interestingly, when you look at them, they're not just doing strength ratios, but they're looking at speed, control in both open and closed chain positions. But what I would say is that there is no one single measure, not one that has been shown to be this is the one you use. It's very much thinking about the athlete in front of you, the type of sport they're returning to, and then all of the things that we've alluded to.
Okay. Thank you.
Thank you, Anju. So it's a very interesting question, conversation, and I'd like to go on for hours and hours. And but see, tonight I was saying to Anju that there is the Sanremo Festival, and we thought about this festival just a couple of days ago, but that's it. We have already decided this date. So this kind of this discussion, this conversation together. So we know that 45 minutes it's usually a very good time to share enough information. And I don't know if there are some questions from the participants. Ci sono domande?
No, non abbiamo domande. Non abbiamo domande attualmente, quindi
okay. So Andrew is gonna be with us. Vuoi dirlo anche in italiano? Andrew is gonna be with us in a couple of months.
Esatto, Andrew sarà con noi in un mese e mezzo, un paio di mesi, a Milano il 22 e il 23 di marzo.
Siamo già un bel gruppo, come dire, però siamo molto contenti se ci saranno altre persone che si uniscono a noi. Dobbiamo essere, ripeto, lo dico anche in italiano, più che onorati di avere esperti del suo calibro a venire in Italia. Fabrizio, che nella sua comfort zone, parlando di spalla, ce lo può confermare. E ci auguriamo sempre che siano eventi come questi ad aiutarci un pochino ad alzare il livello e l'asticella del lavoro che facciamo tutti i giorni per i pazienti e della nostra professione in generale.
Assolutamente, avere una personalità come Anju che ha scritto tanto ed è così appunto ferrata sul topic della riabilitazione di spalla è veramente un'occasione che non si può perdere per tutti gli amanti del settore. Solo così riusciamo effettivamente, come dici tu, ad alzare l'asticella, ad essere anche più concreti e basare la nostra pratica su quelle che sono le prove di efficacia più aggiornate. Quindi
esatto.
Speriamo che il nostro gruppo possa crescere e stiamo tutti insieme, insomma, a
step
parlare
by step. Okay. Thank you, Anju. Thank you, Fabrizio. Thank you, everyone.
Thank you for your time.
Thank you so much. Thank you for inviting me. I look forward to coming to Milan.
See you soon. I'm going to, and the course is going to be translated. So just il corso di Anju verrà tradotto, lo tradurrò io.
Sì, il corso sarà tradotto in italiano, il corso in aula.
Esatto. See you soon, Anju. Thank you so much for your time.
Enjoy your celebration.
Sanremo Festival.
Thank you.
Grazie a tutti, grazie a tutti i partecipanti per essere stati con noi. Buon Sanremo a tutti e ci vediamo il 22 e 23 di marzo con la Masterclass di Anju a Milano. Buona serata a tutti.